I'd like to welcome everyone here on behalf of the Library Club. We've gathered this panel of people to discuss a pressing problem that's we've been hearing about a lot lately, and it's opioid abuse across the country. If it's not doctors prescribing OxyContin, or it's China producing fentanyl, or black tar heroin coming over the southern borders from Mexico. Very complex problem. And they're here to discuss what's going on, what's available on the community level, and kind of let us know what's happening here in Reno. So I think we'll start from, let's see, from your right, and if you will, about 15 minutes, and then we'll have 5 minutes of questions after everyone is through. So if you have questions for the person, kind of allow him or her to finish what they're saying, and then ask the question then. Does that sound okay? Okay, well, I delight in introducing you. Let's see, on right here we have Carla Wagner, Melanie Flores, say hi.
Hello.
Stacy Ward, Jennifer DeLette Snyder, and then we have David Meisner, and let's see, how do I get this messed up here? And then Danny Tillman and David Meisner.
Andrew Servey.
Andrew Servey, I'm sorry. I screwed that one up. Okay.
There's not two of me.
So if you'll start first, if you don't mind, to give us your presentation, 10, 15 minutes, and then some questions, okay?
Sure. Okay. You want to
Yeah,
switch?
and then,
Yeah,
just,
you want me to mic?
yeah, there's a mic
Pretty good
there.
at, can you hear me if I don't mic? All right.
Yeah, you have, a
Pretty
good,
good at
you,
not.
have, you have a voice that carries. So if you want to stand and stride or do whatever you wish, do it.
Okay. I've actually never given it. I have given this talk more times than I can count over the 11 years that I've been doing this work, but I've actually never done it without pointing at a set of slides. So this is a little bit of a new experience. I can show you slides if you want, but I don't think we really have time for that. So I will just tell you a little bit about what I do, what my role in this is, and what I understand to be, or the part of the problem that I work on. So my name is Carla Wagner. I'm a professor at UNR in the School of Community Health Sciences. Oh, you want this? Okay. Also,
I know, there's
wait,
sometimes
that's
they're
me.
not working.
Where's the?
Can you hear her okay speaking?
Okay.
The people from the back of the room need to tell us. Can you hear it okay without it? Okay, so just let it be.
Okay.
You don't want to use it.
So I'm a public health professor. I'm a behavioral scientist. I have been working for about 15 years, specifically with injection drug use and injection drug users and interventions to prevent negative health outcomes among people who inject drugs. I started that work working in syringe exchange programs, which are programs that provide sterile injection supplies to people who use drugs to prevent the transmission of HIV and hepatitis C. But then what we realized in the early 2000s, and even earlier than that in other parts of the country, but where I was working in about 2006, was that the issue that people were worried about and the thing that was killing people right in front of our eyes was opioid overdose. And so I started doing this work on the streets of Skid Row in Los Angeles, where we started an overdose prevention program to teach people how to recognize and respond to opioid overdoses in their communities. Because what we were hearing from people was that they were watching their friends die right in front of them and they couldn't do anything about it and they didn't know what to do about it. But what we knew was that there was something that they could do about it. We knew that there was a medicine that they could use that paramedics had been using for decades to reverse opioid overdose, and we knew that we could teach people how to do it. Because since 1996, people in Chicago have been teaching people how to recognize and respond to opioid overdoses. How many of you have heard of Narcan or naloxone? How many of you have heard of Narcan or naloxone in the past 2 years? How many of you have known about it since 1974 when it was available? something has changed recently in our national conversation around this issue, right? And I think it changed right around 2014. It changed when Philip Seymour Hoffman died of an opioid overdose, and the news articles started saying this could have been prevented. If somebody had been there with this medicine, somebody could have done something, and maybe he would be alive. And that was the first time that I saw in the national media that we were having a slightly different conversation about we can do something about this problem. So, but what you need to know is that this isn't new, right? What you need to know is that we've been doing it since 1996. People in Chicago started teaching people who use drugs to recognize what an overdose looks like, use the medicine, and use the correct response technique to do something about it, and they're saving lives. So I call these overdose education and naloxone distribution programs. Between 1996, when that first program started, and 2010, there were 188 programs across the country. As of 2014, there were 644 overdose education and naloxone distribution programs across the country. Those programs have given Narcan to 152,000 people. Those 152,000 people have reported 26,000 saves that they have used Narcan 26,000 times to reverse the overdose of somebody that they saw. We know from community-based studies that when you distribute naloxone to people who are at risk of dying of an opioid overdose, you can make death rates go down. They saw it in North Carolina, we've seen it in Massachusetts, and we've seen it in California. When we do epidemiological studies that compare communities that have Narcan to communities that don't have Narcan, you can drive death rates down if you get enough Narcan into the community so that people can use it. We also do studies of those programs to see what happens when you teach people to recognize and respond to overdoses using naloxone. So in my research and the research of my peers, we do things like interview people before we teach them, and then interview them after, and then follow them over time. What's the biggest concern? Already, what's your biggest concern with me saying I give medicine to people who use drugs to reverse overdoses? What's the number one thing? We're encouraging people to use drugs. We're creating a safety net. The data that I have and the data that my colleagues have show not only do drug use rates not go up, sometimes they go down. In my research in Los Angeles, people who came back 3 months after we trained them to recognize and respond to overdoses using Narcan told me they were more frequently in drug treatment than they were before, and they were using fewer drugs than they were before. And other people in other places have also seen that in pre- and post-test evaluation studies. Part of what we think is happening is it's sensitizing people to the risk. When we talk about what does an overdose really look like, what's putting you at risk for overdose, how can you prevent that happening in the first place, and then your life is worth saving, and so I'm going to teach you and your friends how to respond. For some people, that's enough to start thinking about making small changes in their behavior. For some people, when they come into a community-based organization and we say your life is worth saving and I want to teach you how to do that and I want to teach your friends and family how to do that, and by the way, if you want a referral to drug treatment, we're here for you and we can do that, sometimes that's enough to help people make that small step. I also work with law enforcement agencies. In Southern California, we've trained deputy sheriffs to use Narcan if they're the first ones on scene to respond to an overdose. And when they do that, they provide a referral mechanism for that person that they responded to. They give them a handout that has a phone number of a case manager, and they get their contact information and refer that person to a case manager. And in our tiny little pilot study, 3 of the 9 people they responded to went to at least one treatment visit as a result of that referral from the law enforcement officer. So we think that these programs we know that these programs save lives, but we think that what they also do is create an opportunity for people to make behavior change and create an opportunity for people to connect to services that they wouldn't otherwise have connected with. So in Nevada, in 2014, we changed our laws. How many of you heard of the Good Samaritan overdose prevention law? A few, right? So Nevada made a very comprehensive change to our state legislation to expand access to Narcan. And that law did many things. But some of the things it did was create a mechanism through which people can go to a pharmacy and buy Narcan from a pharmacist who's now authorized to furnish it to them under State Board of Pharmacy procedures. It created a mechanism by which physicians can prescribe the medicine to the person at risk, but also the friends and family members of that person. And it created lots of protections for people. It also created protections for people when they call 911. What's the biggest concern if somebody's using drugs and somebody overdoses and they're about to call 911? That they're going to get busted, right? So we know in community-based surveys of drug users that it's only about 50% of people who call 911 in the event of an overdose. When somebody's overdosing on an opioid, you have minutes. Minutes count because people are slowing and gradually stopping their breathing. So getting 911 and getting EMS there fast matters. So if people are delaying their call because they're afraid, then we don't call and people die. So there's also protections in the law that allow small levels of protection for people who call 911 against things like charges for minor drug possession. So we've made policy level changes to try to increase access to the medicine that we've been using in community-based programs for over 20 years now.
You're at like 13, 14 minutes ago.
Okay.
Something
So let me give you so this is really easy, and the education part is really easy. So let me give you the thing. When we teach people about this, we teach them 3 things. What does an opioid overdose look like? What do I do when I see it? And how do I prevent it in the first place? So when we talk about opioid overdose prevention, we talk about things like not mixing opioids with other drugs or medications, mixing opioids and benzodiazepines, mixing opioids and alcohol, mixing opioids and stimulants are huge risk factors for dying of an overdose. So we teach people to prevent by not mixing drugs. We teach people about not using alone, because if you overdose when you're using alone, there's nobody there to see you go out and there's nobody there to save you. So thinking about a safety plan. We teach people about using less after periods of abstinence. If somebody gets busted and they're in jail for 3 days and then they come out, their tolerance is down. If they use the same amount, they're going to relapse. If they use the same amount, they're more likely to die of an overdose when they use again. We know that the couple of weeks after coming out of jail or treatment facilities are a very, very risky time for people because their tolerance is down. So we teach people about being safer in those times. And then we teach people how to recognize an overdose. So opioid overdoses kill by slowing down and eventually stopping breathing. So somebody's going to be non-responsive. Somebody's going to have slow or abnormal or stopped breathing. And they're going to look like they're not breathing. What are they going to look like if they're not breathing? They're going to be blue, right? So that's what we're looking for. We're looking for signs of respiratory depression. And then we teach people how to respond. And that's stimulate safely to see if you can wake them up, call 911 to make sure that the emergency medical personnel are on their way, check the airway, and breathe for them. It's the respiratory depression that's killing, so we provide respiratory support. We breathe for them doing rescue breathing. And then we administer naloxone or Narcan if we have it. And then you stay with them and you wait for the paramedics to show up. So it's a small intervention, it's a small educational session, and like I said, 150 more now. The data that I give you, 152,000 people, those were data collected 4 years ago. So there are many, many more people than that who have this medicine now and have had this education. It's more widely available than ever in our history. Almost every state in the nation has changed their law to make it more available. And we are making those same changes here. And there's a lot of people in this room who are working very, very hard on this in a number of different ways. So maybe I will stop there and then see how that goes.
Any questions?
Yes?
Are you working with any drug treatment programs here in Reno? What kind of, how receptive are they?
I have talked with lots of folks, and some are more receptive than others. You could imagine that this might be a little bit culturally inconsistent with,
Abstinence only
yeah.
is typically a
But here's the thing. Even if somebody leaves treatment and does not use again, they are going home and potentially going home to a community where other people are using. And so creating a community safety net where lots of people have this education and have this medicine and have these skills is good for the broader public health.
What is safe stimulation? Is it just a sternal rub?
Yeah, exactly. Do you know how many, where's, there you are. So paramedics, law enforcement folks, they do this sort of sternal rub, knuckles on the sternum. causes enough pain to wake somebody up. Is this what you guys
It's really
do?
quite tight on yourself.
Or on the nose, the bridge of the nose.
Yeah, it just keeps them going.
Here's the other thing I will tell you. The safety net concern, and like if people have enough Narcan, then they're going to keep using and they're going to use more because it's going to be safe. What naloxone does is bind to the receptors in your brain that the opioid was bound to. And it takes over it, outcompetes that opioid and binds to that receptor, which means it takes away the respiratory depression, but it also takes away the analgesic effect, and it takes away and it puts you into withdrawal. If you're opioid dependent, naloxone will put you into withdrawal. So it feels really bad. And so, people in communities where people have been woken up with naloxone by paramedics, if you tell them you're getting the naloxone out, and they're not totally out, that might be enough to get enough of a stimulated response, because it feels really bad. The idea that people are just going to keep using and using and using more because they have a safe way out, it doesn't feel good to be in withdrawal if you're opioid dependent. And people know that.
How long does that last for?
Naloxone has a short half-life, 30 to 90 minutes-ish. Opioids can have a much longer half-life, especially long-acting opioids. So things like methadone last for much longer. And that's why 911 is your first call, because the naloxone will wear off and the opioid could come back. The other reason 911 is your first call is because if that person had mixed benzodiazepines and heroin, or benzodiazepines and oxy, or alcohol and oxy, the naloxone is very, very specific. All it does is bind to that opioid receptor. So it's not going to treat anything else, which means if you have some other weird synthetic drug on board, if you have alcohol on board, if you have other medical complications, the naloxone's not going to fix it. And so you need to have paramedics on their way.
Okay, no more questions? Thank you very much, Carla. Much appreciated. Okay, Melanie Flores, do you have any film or any slides or anything?
My name's Melanie Flores. I'm actually a program coordinator at Washoe County Health District. I oversee the Community Health Improvement Plan. But I'm also a community organizer and a founding member of the Public Health Alliance for Safety Access. So I'm actually going to speak to you today a little bit more about what we call PHASA did in the whole bringing this issue to the forefront in Nevada, and then I'll give you a little bit of what Washoe County Health District is also doing. So it's really nice to see a lot of fresh, young student faces in the crowd, because this whole project stemmed from being a student. And I'll tell you a little bit more about that. So technically, PHASA, this is a very generic mission statement, but we create policy, system, and environmental changes to promote health and well-being in Nevada. That's the generic term of what we do. It doesn't really tell you specifically what we do. I will tell you it actually stemmed in 2010 when PHASA was an ad hoc policy committee to the State AIDS Task Force. And at that point in time, they were looking for comprehensive strategies to reduce HIV in Nevada. And one of the only strategies they were not able to implement was the syringe service programs to reduce HIV prevention among injection drug users. And as a result, they pushed forth legislation in 2011. Unfortunately, that legislation died. And then that's where I came in as a student. And actually, it's one of those things where a cause, you don't always choose your causes. Sometimes your causes choose you. And that's exactly what happened to me. In, let's say, October 2009, this cause chose me when I got a phone call from a friend telling me that somebody very, very close to me had died of a drug overdose. That completely changed the trajectory of my entire life. I was not in public health, that's for sure. I was doing my 12-year career in alternative rock radio, and that's what I thought I was gonna end all be all, and that's not what happened. As a result, that changed, obviously, my perspective on life, and I went back to school, and I got my master's in social work, and I ended up at Northern Nevada Hopes, which is at the time was an AIDS service organization. And my boss at the time, she put SB 335, which was the first syringe service program bill, on my desk and said, Mel, I think this is something that you'll be interested in. And that moment had dictated pretty much the last 7 years of my life, which is kind of interesting. So as a result, the Public Health Alliance for Syringe Access, later Safety Access, came to fruition and took a life of its own, and actually ended up sitting down with Carla Wagner for eventually the naloxone access bill at some point. I'll go into that a little bit. But I have to start with the history of PHASA, because if it wasn't for syringe service programs starting in Nevada, I'm not sure. I'm sure it would have came to the forefront, but I think that's where the conversation started happening in terms of drug use, substance use, opioids becoming an issue in Nevada. And it wasn't even just my ex-boyfriend dying of an overdose, but I also found, being in the whole field of sex, drugs, and rock and roll, that a lot of my friends had heroin or pill addictions as well. So this very fast became a passionate issue for me. So this was the original bill in 2011 that died. And the reason why I bring it up for you guys to see is because this started everything. As a student, what I did, because I had the luxury of doing all this research and having time to actually dip into this, the State AIDS Task Force, they kind of disengaged after it lost in 2011, which didn't happen when a bill doesn't pass. And so as a student, I was very passionate about it, and I said, hey, I really want to take this on as my thesis project as a master's student. So that's what I did. So I did what I say is policy forensics to figure out what went wrong in 2011 so that we can cure that in 2013. So this is what we came up with. The language. So the original language of the bill was very regulatory. And so what happened is when you have regulatory language, immediately a fiscal note gets slapped on the bill, and a fiscal note is very bad if it's not in the governor's budget and can kill your bill immediately. So immediately we changed the language to be more decriminalization type language, which allowed organizations who wanted to implement a syringe service program to actually do that, but it didn't have any severe regulatory, like you didn't have to do it. You did it if you had the money and you wanted to do it. And then you just had to abide by the state's regulations. The initial bill, we had law enforcement opposition. We actually had the National Association of Law Enforcement come out in opposition of the bill. They said it would increase drug use, it would increase needle sticks, and also they weren't engaged at the beginning of this bill. So we thought, red flag, you really can't do anything in Nevada without the help of law enforcement. So that was something that we needed to work on. And then we didn't have any local research or data whatsoever. We had a lot of data from California, from other states. If you're from Nevada, the minute you mention California, you get shut down really fast. So it was really, really important for us to have our own local data and research. And then we had a lack of testimony from the injection drug using community themselves, or anybody who've used a syringe service program, anybody who lost a family member as a result of drug overdose. And so as a result, this actually came from Assemblywoman Teresa Benitez Thompson, who's also a social worker, and she said, where's the drug using community? Would they even use this? And what was interesting coming from HOPES is we would work with that community every day. The fact that we couldn't bring somebody to testify on behalf of the bill was almost embarrassing. So as a student, I thought I could help, at least with the data piece of things, and so I conducted a statewide needs assessment for syringe access. I won't go into the data because it's horribly outdated, and any of these people at the table could give you much better data than what I had back then. But in terms of painting the picture of injection drug use in Nevada, we actually had to use national numbers to try to estimate, because it's not like we're tagging and logging injection drug users, right? So to figure out how many we would have in Nevada, actually Stacy, I had to talk to her to get data from local law enforcement, Las Vegas, just to find out heroin arrests, seizures, paraphernalia arrests and seizures, went to substance abuse treatment centers, things of that nature, HIV, hepatitis, B and C rates in Nevada, just to paint that whole picture of burden, that this was an issue, so people would listen to me. And then the other thing was kind of assessing readiness. Was Nevada truly ready to implement something like a syringe service program? And so we did surveys to leaders, politicians, CEOs of organizations, but also drug treatment centers, church congregations, law enforcement, just to assess whether our community was ready. And then we did focus group with former and current injection drug users in both Northern Nevada and Southern Nevada. And as a result from those focus groups, which were hugely eye-opening, were that we got to enlist people to speak on our speakers bureau, to testify at the legislature, and to become advocates for their own health care in Nevada. And that was probably the most impactful part of this whole process, is that eventually, you know, the CEO of Hopes wasn't the voice anymore. It was somebody that was a former injection drug user who used a syringe service program. It changed their life, and they were the forefront of this whole issue in Nevada. So community mobilization is definitely where I came in. So I started out as a student like you. I did the research, I did my thesis, and then Harm Reduction Coalition out of Oakland and Northern Nevada Hopes put together funds and hired me on as a community mobilizer to help with some of these issues. So we had to identify key champions in the state. You do need certain people to get you through certain doors. That's just the fact of the matter. So we needed people in high political positions, and then we also needed people that could get us into drug treatment centers, or that could speak to other or former or current drug users, and or cops, law enforcement, things like that. So you needed people, champions in all different sectors, to talk to all different kinds of people. We had to leverage our relationships, and then we also had to diffuse the opposition. So as I said, law enforcement was huge in terms of opposition at the beginning, but we learned really quick that it was mostly because we didn't engage them from the beginning, and also there was a lack of education in Nevada just in general. And so we realized that we really had to get out there and get the best practices and the data out there for people to understand what was going on. And then we built a speakers bureau and a group of people that were ready to go if they had to testify, if they had to do an interview on the news, or if they had to go out and do a talk like this. And then we needed somebody to be ready to implement. So once the law is passed, who's actually going to implement a syringe service program? And so as a result, Northern Nevada Hopes came to the table, and we were so lucky at that point that Sharon Chamberlain, she came from LA, and worked in syringe service programs down there as well. And she was the new executive director of Hopes. And she said, you know what, I'll figure it out, but Hopes will be the first organization in Nevada to have a syringe service program. And part of syringe service programs actually is naloxone distribution in a lot of states as well. So you could see how they're very interrelated, but I will go into both. So our key champions here for the first bill anyways was, we were an ad hoc policy committee, which means we needed a main body or organization to be a part of, and for legitimacy. And it was a state AIDS task force, but since they were no longer really meeting at that time, we ended up going underneath the Northern Nevada Outreach Team, which is a coalition of organizations concerned about sex health and HIV prevention. And they not only took us on as an ad hoc policy committee, they incorporated our initiative into their strategic planning, and all of their volunteers got backed up everything that we were doing. So it was a really beautiful partnership. We also had Dr. Iser at the time. He was the health officer, and he came from California as well in Yolo County, and was very familiar with syringe service programs. And as a result, he was a huge champion for getting us into doors that a basic grassroots organization couldn't. And he also massaged our relationship quite a bit with law enforcement. Sharon Chamberlain, as I mentioned, and you know, Nevada's really small, and I went to school with Stacy Shin, who ended up being the lead lobbyist for the Progressive Leadership Alliance for Nevada, and she ended up lobbying our bill. So, you know, it's all about who you know sometimes. And then we had to legitimize our presence, so just building a brand, website, social media, hosting monthly calls, actually flying down to Vegas. They're the majority of the population in Nevada. You can't really move a lot of policy without them. And so we had to make sure that everybody was on the same page. And we had to do quite a bit of community education, community presentations, outreach, developing that speakers bureau. We brought in Harm Reduction Coalition for a lot of capacity building, so they would hold trainings and do technical assistance and consulting, such as working with law enforcement, or they even brought in a chief of police from Washington to talk to our law enforcement, so that way it was more a peer-to-peer based education, and it wasn't me, who has no idea about law enforcement, telling them what they should be doing. Instead, it was somebody in their peer telling them how they implemented it in their county and could address their comments, questions, and concerns. So we definitely took an approach of community activism, if you will, and very grassroots. So you can see these are some of our advocates, actually. The girl used to be a drug dealer, and the gentleman on the left is a former injection drug user, and they were together at the table and for this cause, which I thought was pretty amazing. Yeah. Okay. Ooh, okay. I'll go ahead and skip. So the strengths of this campaign was that we utilized focus groups, consumer advisories, we enlisted the Speakers Bureau. We had a year to prepare for the first bill, which made it so much easier for the second bill, because we already had a well-oiled machine in terms of advocates that came to the table. So when Carla came to the table and said, hey, are you interested in getting involved with the naloxone access bill, which is SB 459, we were able to engage in a 2-month time period, which is like unrealistic for most people to help. So that was amazing. Some of our challenges, well, after I worked at the state for 4 years as well, so now I know the state comes out neutral on everything. But at the time, we really were like, what? We thought they were going to support, and they ended up coming out neutral. And I kind of already addressed some of the others, like Nevada hates California. There was a lot of massaging we had to do. We had to do a lot of education to legislators. Some legislators thought we were taking needles and actually cleaning them in the back in a kitchen and redistributing them. So a lot of education. So we had success, and I say rinse, repeat on the naloxone access bill, because we did a lot of the same activities to push forth this. This was a lot easier, though, because Kathleen Sandoval was a champion, the first lady, and we had a bill, and they had a bill. We ended up merging the bills because they were pretty much the exact same, and so that made it a lot easier to push forth the naloxone bill. There are slight differences, as I said, the time difference in terms of turnaround, merging the bills. Of course, the advocates changed, Carla being one of our big ones, Judge Dorothy Nash Holmes, another one. And the branding changed to Public Health, Public Health Alliance for safety access rather than syringe. So I'll go ahead and just end it there and take questions.
Are there any questions for her?
Who funds the new syringes?
You know that I think a lot of Northern Nevada hopes, even though they do have federal funds, they support it through their general fund and foundation and fundraising, from my understanding.
Just offhand, do you know what that costs a year?
I don't know how much that costs. Do you know?
No, I have no idea. But I can tell you that people have done cost-effectiveness studies for 30 years, and it is much, much cheaper to fund syringe exchange programs than it is to fund HIV and Hep C meds. But I don't know how much it costs to run a program.
Other questions? No? Then we'll continue on with our panel. Stacy, do you have some
I have
slides?
a PowerPoint on there,
Okay.
yeah. If you're able to pull it up. Is this microphone on? Yes, no? Okay. Is there a clicker?
Yeah.
There's a clicker.
Can I make a comment?
Climb over you. Yeah.
So as I was listening to Mel, I was having this thought that after hearing what I just said and after hearing what Mel just said, it might be possible to walk out of here and think, this is not my problem, because this is a problem that drug users have, and I am not like those people, right? And this is the social process of stigma and social distancing, when we create an other and we say that this thing is somebody else's problem.
Reno Police?
Perfect.
This is not somebody else's problem, this is our problem, right? I am not talking exclusively about people who live on Skid Row and inject heroin. I talk a lot about them because that's the community I work with. But we have so many opioids in circulation right now. Opioids through prescription, opioids that are getting diverted. My mom has opioids on her kitchen counter, right? It is all of our jobs to increase access to the information and the medicine that can prevent people from dying. And it doesn't matter if these are legally or illegally obtained opioids.
I have another question. You said that you had some pushback from Vegas. Is there a program similar to Northern Nevada?
Well, there's a program similar to Northern Nevada Hopes, but not Change Point, which Change Point is the syringe service program at Northern Nevada Hopes. There are individuals that are trying to create something right now, but as of now, there's nothing similar. So right now, Change Point is the very first one and only syringe service program in Nevada.
So there's no needle exchange program in Vegas? Wow.
I mean, not to say there aren't backpack efforts and people kind of just doing grassroots type of stuff, because there are and there was before the law even happened. But yeah, something formalized, no.
Is there a panel like you or people like you down there working on these problems?
Southern Nevada Health District, I know are a little bit.
It's just a larger monster down there. Okay.
Okay, I'm Stacy with the Reno Police Department. So I'm a civilian with Reno PD, and my job there is the drug prevention coordinator. So it's my entire focus to do these types of things, outreach with the community, educating the community, stuff like that. So what I'm going to talk about is just what Reno Police Department has done at the local level to respond to the opioid crisis. The opioid problem came onto our radar in about the middle of 2009. And so since then, Reno PD has been focusing efforts on this, and then I'll just kind of go through what all that has entailed. So the first major project that we undertook was called the Smart Policing Initiative. It looks like you can pretty much see all of the text on the slide, so that's good. So the way this came about, in the spring of 2009, there was a local couple that came forward to join together Northern Nevada, the organization that Jennifer represents. They came forward and they said, our son Austin, who was 15 years old, just died of a methadone overdose. He was out at a party, he came home, said goodnight, kissed his mom and dad goodnight, went up to bed, and then in the morning his mom went into his bedroom and found him dead in his bed. So they came forward. He wasn't really a drug user. He hadn't really been in trouble or anything like that. It was a shockingly small amount of methadone that he took. But for him, in combination with something he was legally prescribed, it turned out to be fatal for him. So his parents came forward and said, we don't want anybody else to have to go through what we're going through. We don't want this to happen to other families. So what could we do that could maybe prevent this in the future? So Join Together Northern Nevada reached out to the Reno Police Department. We were fortunate to already have a very good relationship with them based on working on some other substance abuse issues. The meth problem in particular. Anybody heard of a meth problem in Nevada? Yeah. That hasn't gone away, by the way. This is where the focus is right now, but we still have an enormous meth problem. But because of that, we already had some partnerships in place. So what we did is we all met together with those parents, and we just kind of brainstormed what could we do. One of the first things we did also was to look at our internal data. So my supervisor at the time said, I don't think we even really have a prescription drug problem, but can you take a look and see? We don't have a whole lot of data at the law enforcement level about prescription drug abuse because there's obviously a legal realm for using those drugs, right? It's not inherently illegal like heroin is. What we did look at was our heroin data. Heroin is an opioid just the same as prescription narcotics are, and we had a 3,800% increase in our heroin seizures over the last few years to that point. So we said, wow, obviously we do have a big opioid problem. So we designed a prevention plan, and then we applied for the Smart Policing Initiative funding, which is a national grant from the Bureau of Justice Assistance. We were fortunate to receive that funding, and so it was initially a 2-year grant, and then we were refunded for an additional 2 years. So it ended up being, with an extension, about a 4.5-year project. The objectives of the project kind of broke down into 3 areas. So one of them was education. This included educating healthcare professionals. So we put together several continuing ed classes for prescribers as well as pharmacists and pharmacy techs. So there are a lot of, and Carla kind of talked about this, there are a lot of different pieces, right, to the opioid problem. There's no one sector that you can target and hit it all. So with prescribers, we talked to them about a lot of different things, identifying kind of red flag behaviors when a patient is in your office and they're just trying to scam you for drugs. Basically, they told us in some survey data that they had no training on that whatsoever. But they did simultaneously report that they encountered drug-seeking patients, what they identified as drug-seeking patients, regularly, at least weekly. So we educated them, and then as well about just some alternatives to opioids, depending on what the problem is that the patient's presenting with. And then on the pharmacy side of things, it's a lot of fraud prevention. So if you're going to obtain narcotics, prescription narcotics, you have to go to a pharmacy, pretty much, right? Unless you steal them off of a truck or from the manufacturer. And so we educated the pharmacy community about identifying fraudulent prescriptions, you know, people that are calling in prescriptions for themselves that are not even originating from a doctor, things like that. We also, on that first point, educated just the general public about prescription drug abuse too, and Jennifer's going to talk more about this too, so I won't really linger on that. Increased enforcement of prescription fraud and diversion laws. So what this looked like was, prior to 2010, Reno Police and pretty much all law enforcement in Northern Nevada had nobody dedicated to working prescription fraud at all. So we have people dedicated to working drug crimes, and we have people dedicated to working fraud, but prescription fraud, stealing prescription pills, was getting missed. There was a gap. So we dedicated people to that. And primarily what this looked like is we have had rings of people come into the area, often from California. That's just where they happen to be from. Come into the area. It's a very organized setup. They'll steal prescription pads. They'll print their own prescriptions. And their goal is just to obtain as many pills as possible and flood the community with them and sell them. So this was our target. Our target was not a soccer mom who inadvertently got addicted to her pills. We have no interest in seeing her go to jail. In those cases, actually, we've had our detectives testify on behalf of some of those individuals and lobby for them to try to get into drug court so that they can go to treatment instead of jail. So we understand that there's a very important distinction there. And then reducing the availability of prescription drugs is probably what the bulk of our kind of day-to-day activities had been under that program. And so this I talked about on the prescriber education. We did some surveys and we were able to see through a couple of different means whether the education was effective so that we would know, is this worth spending your time on in the future? We saw that for the doctors who attended a training event that we put on, they subsequently decreased the amount of controlled substances they prescribed by, you can see there, almost 18%. And then similarly, they wrote 117 fewer prescriptions per month, which was about a 16% reduction. So that told us that, you know, they do listen in these trainings. By and large, the majority of doctors, in my experience, are well-meaning. They became a doctor because they want to help people. When a patient comes to them and says, I'm in excruciating pain, then they want to help, and they often don't know what else to do besides give that person pills. So a lot of it was just educating them about alternatives and having an exit strategy if you're starting somebody on opioid therapy, things like that. There are outliers, of course. There have been doctors. You all may have heard of a doctor in the area who was arrested recently, but that's the minority by far. As far as reducing availability, the main thing that has looked like from the Reno Police Department is the prescription drug roundups. So has anybody heard of this event? Okay, so what we've done is the first event that we held in Washoe County was in October of 2009. We didn't invent the idea, but I looked and saw that some other states in the country had been doing similar things. The idea is that if you have extra pills lying around in your house that you don't need, and you don't really know what to do with them, you don't want to flush them down the toilet, you don't want to just leave them in your medicine cabinet, you can bring them here and just dump them and we'll destroy them for you. So we've repeated that twice a year ever since that time. As of right now, we've had 16 events since October 2009. And we've been logging what comes in. We've collected about 2.1 million pills at those events. So this is just a photo from one of the early events. In that photo is probably only maybe 50,000 pills. But I will tell you, we were all shocked at the quantities of medications that people are bringing in. We have people in the community, largely elderly people. In many cases, they've had a spouse or a parent pass away, and so there's just a stockpile of medications sitting there. The problem with that is if anybody in your life, whether it's your grandchild's friends, a plumber who comes to your house, if anybody wants to divert some prescription pills, then they're just going to walk into your medicine cabinet and take them. So that's what we were trying to get at, and the prescription drug roundup affords an opportunity to educate the public about why should you care if you have prescription painkillers sitting in your house. Why should you be extra careful to lock those up if there are any children in your house, or anybody really, things like that. So that's how the prescription drug roundups have gone. They've been hugely successful, and the number of pills that we collect has gone up and up and up with every event. So unfortunately, it's not tapering off. There's still a huge need for that. To give you an idea, I said we've collected about 2.1 million pills over the last 8 years. We also looked at how many prescriptions are prescribed in Nevada. So this is just controlled substances. This doesn't include things like antibiotics, heart medicine, just controlled substances. Over 44 months in this study period, we had 14,861,000 prescriptions filled in the state of Nevada for a total of 1.1 billion pills, an average of 25 million pills per month, 337,000 prescriptions per month, and Nevada's population is 2.8 million people. So unfortunately, the amount of pills that we've recovered from the drug roundup is actually a drop in the bucket in comparison to how many prescription controlled substances are in the state of Nevada. Of course, a lot of those we hope were prescribed for a legitimate need, and so the patient took them, and they're not going to show back up at the roundup. But we know, since we've seen the numbers go up and up and up at the roundups every year, that a lot of those pills are not actually ever used, and they're just sitting out there, floating out there in the community. And then this is what the Reno Police Department is doing now. So the Smart Policing Initiative ended in the middle of 2014. We knew that we hadn't fixed the problem by any means by that point. So we've initiated a new project and obtained some new funding. This one is primarily research-based. So it's called the Harold Rogers Prescription Drug Monitoring Program Grant. The Reno Police Department has that grant, and then we also actually have a grant at the state level too from that program. So this is a partnership between Reno PD, UNR, we have an evaluator that we contract with at UNR, and then the State Board of Pharmacy as well. And primarily what we're doing is analyzing the PMP data. Anybody know what the PMP is? Nobody? I know a couple of people in here know it. So the PMP is the Prescription Monitoring Program. So every controlled substance that is prescribed in the state of Nevada goes into a database, and that's the Prescription Monitoring Program. And so the purpose of that was for physicians to be able to go in and check it. So if you show up at a doctor's office and you say, I need some Vicodin, the doctor can look and make sure you didn't already just get Vicodin yesterday, that you're not already taking a benzodiazepine, which presents a huge overdose risk if he gives you narcotics, things like that. What it also allows is for some aggregate data analysis. So there's a lot of data just sitting in there. If we're able to de-identify it, take away people's names, we can get a lot of information out of it. So that's what we're working on now. The focus areas are identifying populations that are at high risk of abuse and overdose. We've identified, I think, 8 or 9 metrics that we're looking at, including things like a combination of a narcotic and a benzodiazepine, combination of those two and a muscle relaxer, and then several other different things that indicate somebody's at high risk. We're educating prescribers again, like we saw that was effective. And then we're analyzing the link between prescription drugs and heroin. So we knew anecdotally a long time ago that people do, in some cases, graduate to using heroin after using prescription narcotics. They work in your body essentially the same way. The withdrawal is the same. And so either one can be substituted for the other to stop withdrawal, to prevent withdrawal. And so what we're looking at now is are there any common factors that exist in people who do make that jump? A lot of people don't. A lot of people only ever use prescription opioids. But some people do graduate to heroin use, and that's really the worst case scenario as far as we're concerned. We don't want them to end up there. And so this research project, we're only about halfway through it. We don't have any findings to publish at this point. But we're hoping to identify if there are any risk factors for somebody to make that jump to heroin. That's where we want to intervene. That's where we want to educate them. That's where we want to educate their doctor. Whatever it is we can do to keep people from ending up in that spot where they ever even need naloxone at all. So that's kind of an overview of that. I think those are all of my slides. Yep. So questions for me?
Thank you, Stacy. Do we have any questions for her?
Of course.
Hi, Camille.
So, you were saying the Nevada pharmacy, does the veterans operate differently, the VA?
The VA operates differently, so because it's a federal entity, the VA is not required to report their data into the prescription monitoring program, which is an issue. There are a lot of controlled substances prescribed at the VA, and so we're kind of missing that. However, the VA is interested in voluntarily reporting into the prescription monitoring program, which is good. And if they would like, the prescribers at the VA can also obtain an account and they can query the PMP. So they can log in and look and see. But it's just because they're not required to input the data, there may be some that we're missing. But the Board of Pharmacy is working with the VA and trying to get all of that ironed out. It's a problem nationally too, because the VA is a national entity and every state's prescription monitoring program is a little different. Every state law is a little different, so there's just some red tape that we're working through. I say we because I also work at the State Board of Pharmacy, as an aside.
I think you called it the prescription monitoring program. Do you have any data on how easy that is for doctors to use and their rate of accessing that database?
Their rate of accessing it, no. We can obtain that data. It's a little bit difficult to fish out. That have used it or that have logged, that have obtained an account? Yeah. So in Senate Bill 459, which was mentioned, it became mandatory for prescribers to check the PMP in certain situations. So in effect, all prescribers are required to have an account in the PMP. So now we're nearing 100% compliance with that. The next step is going to be making sure they actually use it. That's having an account. The next step is, do they actually use their account? And there's not a whole lot of available data on that, to be honest with you. But it's something we could get. We can look and see.
I think that would be critical. If the database is great, but if it's not being used.
Exactly. Yeah. And so one of the issues has been the software vendor has changed a couple of times, and so previous systems were not as easy to use. But I can tell you, since I work there and one of my functions is to get people signed up, it's very easy to use. It's an online setup. It takes about 10 minutes to sign up for an account. And then to log in and check somebody's history takes, 2 minutes. So it's pretty simple.
Great. So any other questions here? So we'll move on to our next board member, Jennifer DeLette Snyder, Executive Director of Join Together Northern Nevada.
Okay, I'm Jennifer DeLette Snyder. I'm the Executive Director of Join Together Northern Nevada. We are a substance abuse prevention coalition here in Washoe County. We are one of, we'll see if I can get this to advance. We are one of 12 coalitions in the state that make up the Nevada Statewide Coalition Partnership. Do you all know what a coalition is? I mean, I've got it on the screen, but we all coalesce. We get together over certain topics, and ours, of course, is substance abuse prevention, so we may coalesce over marijuana or prescription drugs or whatever the topic is. Maybe, like Stacy was saying, that the family who had come to us back in 2009 when they were trying to figure out something to do so that their child's death wouldn't be in vain. That's something that we met with law enforcement and others just to determine what we could do about it. So that's what we do on a daily basis. We're a pretty small agency, but we have a lot of partners in the community, and that's how we get our work done. So we engage the community in a myriad of ways. We have committees, we have partnerships, and we also have a comprehensive community prevention plan. In 2009, when this family came to us and we went to Reno Police Department, we created the Community Prescription Roundup Committee. So Stacy named our roundups, and then we named the committee after the roundup. So, so we started meeting in 2009, and this committee, among other things, plans the roundup activities that we do twice a year. And this was, I think Stacy said this, even before the DEA had created the National Take Back Days, we were doing this here locally. And so we were very organized, and I have to give Stacy a lot of credit because she's the one who got volunteers initially. But we have so many people involved in this event now. We have people who count the pills, as she said. These are volunteer pharmacists. We have people from the Retail Association. Just there are so many people. It takes about 50 people at least before you have law enforcement involved every time we do one of these events. And it's a very fun time. If anyone ever wants to volunteer, feel free to see either of us, because it is interesting, like Cece said, to see the people with their bags over their shoulders like they're coming down the chimney, but it's with pills and not presents. So this committee also has a subcommittee that looks at physician education. I think Stacy and I are the only ones on it right now, but we have had others involved in the past. And we created a senior roundup. That is not to round up seniors, that is to round up their pills. And so we do this at various senior sites in Sparks and Reno during the roundup. It's usually a couple of days prior to the main event. And then we also started a roundup over the Reno Sparks Indian Colony. So we've done that twice. We're going to do it again here in the spring. Okay, so in 2009, like Cece said, we noticed a problem too. We were hearing about it. We started, my job at the time was helping create physician education, not just physician education, but education in the community. And so I brought in a couple of physicians, and they were talking about a drug called Suboxone that we all have heard about now, maybe, but nobody had really heard about it in 2009. And so then I started thinking, well, wait a second, maybe we need to back up, because we need to figure out how do we even get to the Suboxone piece. Maybe we're overprescribing. So in 2010, we started partnering with the School of Medicine at UNR to develop prescriber trainings like Stacy talked about, and we've partnered with RPD and others in the community to deliver those trainings since 2010. We've developed promotional items, and there's some items back there that you'll see. We've got a rack card. Feel free to take that. We have a naloxone brochure that we just did, and some other things up there too. We've done billboards, we've done public service announcements, any way we can get information out to the public. We've done funny ones, we've done serious ones. It's really just kind of engaging people on either about the roundup events, safe storage, just kind of risky prescribing, that type of thing. And we also established permanent drop boxes across the state. So Stacy and Reno PD purchased the drop boxes for Washoe County, including Sparks? Yeah. And then okay, so Reno and Washoe County Sheriff's Office. And a grant with the coalitions of 12 partners, we were able to purchase those drop boxes in the rest of the counties. So each county has one at a law enforcement office. So no matter where you are in the state, if you have drugs that you want to get rid of, you can get rid of them through the lobby of the sheriff's office or, Reno Police Department, wherever that is. We also, I think I forgot to mention this, with the prescription drugs, and it may be on another slide. So Washoe County was the first in the state to have an official prescription drug roundup. Every county in the state now has one. We all do them at the same time. So we shared that information with our coalition partners. We all do it at the same time now. Here we go. Here's the plug. April 29th, if you have pills, bring them to, you'll have to look at our website because I didn't put them on there, but at jtnn.org, we have, and I think there was a sheet back there too for you. We have 6 locations here in Washoe County. Las Vegas will have some. I don't think any of you are from Las Vegas, but if you have friends, let them know. You can also go to the DEA.gov website, and that lists every location in the entire country for where you can drop off your drugs on April 29th. And every time they have a take-back event, those are listed on the DEA website. This is what one of the permanent boxes looks like. This is the one in Sparks PD. They're located in Reno PD's lobby. Washoe County Sheriff's Office is back toward the back going into a booking area. This one is like right when you walk in the door. I think this one's probably the most easily accessible depending on where you live. These are permanent. They're open during lobby hours. The other coalitions have them, like I said, in their communities as well. We are lucky enough to have one Walgreens, the one over the freeway and on Virginia, that is now a 24-hour drop box. So there's no excuse if people say they can't find a place to drop off their pills and they want to flush them down the toilet. There's no excuse. We have a 24-hour drop box here. It's the only one we have in the north, and there are 5 down in the south at Walgreens. Okay, so let's say you cannot get to a prescription drug take-back event, you can't get to a permanent disposal site. We have these doTERRA bags. We have, our state was lucky enough to be the recipient of 80,000 of them from Mallinckrodt, who is the distributor, manufacturer. So if anybody in this room would like something like this, please let me know. And we have a couple hundred at our office, but there will be about 40,000 for the northern part of the state. It's very easy. This one takes 90 pills, and you just tear off the top. You put your pills in, you fill it up with water, seal it. It kind of bubbles up. It's got these like charcoal packets in here, and then you just toss it in the trash. If you don't have that, you can still do the same type of, I mean, it's not going to bubble and look fun and all that, but you can still put it in, your pills in with, use kitty litter or coffee grounds, put it in a plastic bag and throw it in the trash. Okay, safe storage. I had another flyer up there for you. If anyone wants a free box, we have some, they look like that. We have a couple of different sizes. This is for people who have narcotics, anxiety medications, benzodiazepines, other addictive prescription sedatives. If you have these in your home and you are trying to keep them out of reach of younger people or other people, which you should, we encourage you to not lock them up. If you bring that flyer to my office, you will get one for free. If you don't have that flyer or you don't want to use that lockbox, anything with a lock will work. As far as toolbox, file cabinet, a safe, anything like that. But please, if you do have narcotics in your home, it's a great idea to keep them away from the hands of others. Okay, this is a terrible slide to show everybody. I didn't realize how small it was going to look. So back in 2013, I apologize for that. I'll briefly tell you what it is. Back in 2013, the state applied for a Partnerships for Success grant, and the coalitions, we helped write that application, and then the coalitions administer that grant to some degree. And what we looked at is we were looking at strategies that have been used, best practices through the rest of the country. And I might have to turn around to look at this. Okay, so the reducing inappropriate prescription use, that is back to the training of physicians and the public. Stacy's talked about that. We've talked about that. Reduce access to drugs, that is the prescription drug take back, everything I just talked about. Improve overdose intervention. This is making sure people understand about naloxone and the Good Samaritan law. As has been said about the SB 459, the Board of Pharmacy regulations weren't permanent. Everything wasn't in law, I guess, until the end of last year. And so now that everything is in law and people there's a standing order, they can go to pharmacies and get naloxone. We are doing trainings now on naloxone and the Good Samaritan law. We've got substance abuse prevention. That's trainings for trainings for parents and youth. The middle one is working with mental health. We have a program called Mental Health First Aid. And then this one over here is really making sure that we work with our treatment and recovery friends. So we really looked at this as all of these strategies. In order for us to make a difference in the community as a coalition, we have to work with our partners, and we have to hit all of these different aspects of prescription drug abuse. Okay, so our partners, again, tiny, it's very hard to see, but hopefully you can see on this one. I've got a couple of websites for you. These are resources. The first one is healthierNV.org, and that is a website that the Nevada Statewide Coalition Partners created a couple of years ago, right before the last legislative session. And there are resources on there, whether you live here or in Vegas. You can find a place to go for detox, you can find treatment, you can find someplace to do an assessment. You can also find other information on there. There's also information for physicians as well. Stacy talked about the prescription monitoring program. We did some trainings for physicians on the PMP. We had a cute little flyer that we would go to their offices, and we would create trainings, usually with the hospitals, at maybe 12 to 15 people at a time. And you were asking about the PMP. It was so quick. First of all, it was really fast to get them set up, and then for them to use it. They were surprised at how quick it was. Of course, they didn't all want to use it, but we were charged with helping them understand how to use it. And then we also collaborated recently with the licensing medical boards in our state. They came up with a new website called knowyourpainmeds.com. It just debuted a couple of weeks ago. go to this site. There's a lot of good information. If you suspect somebody is over-prescribing, whether it's a nurse practitioner, a DO, physician, or you suspect some funny business going on, if you go to the site, you can put information in and it will go to that specific board. But they are going to be coming out with a media campaign soon, too. And then we have, like I just mentioned, we are working with REMSA to deliver some naloxone and Good Samaritan presentations. And our comprehensive community prevention plan, we just released that today. That's a plan that we do every 2 years. We look at the community, look at the data, and we do focus groups as well as surveys to gather information and make sure that we are focusing on what the data tells us. That website, you cannot see it, but if you go to jtnn.org, you can get to our community prevention plan there. Just a couple of things from that data. In the focus groups, prescription drugs they were in the top 3 in every single focus group that we met. We talked to youth, we talked to adults of different shapes, sizes, colors, ethnicities, everything. Everybody said prescription drugs were at the forefront and were dangerous in our community. We have almost 1 in 5 high school students who have said that they used a prescription drug without the need of it for non-medical use. The computer-aided dispatch calls for heroin rose 550% in just 1 year. That's 2014 to 2015. So these are the calls that you're making to 911. They started tracking those. And in Washoe County hospital admissions, that data, 2010 to 2015, the number of opiate admissions doubled in that year. I'm sorry, in those 5 years. So that's all I have.
Thank you very much.
Sure.
Are there any questions for her? I have a question. Was the 550% increase because you brought in a new way of getting at the material? I mean, that computer aided.
No, it was just what they were doing is any call that came in, if the person used the word heroin in the call or opiate, they tracked it. They have been tracking it since I think 2010, and there were only maybe 30 a year until 2014. That 2014 to 2015 jump then.
So there was a severe spike
Yes.
over that year.
Mm-hmm.
Okay, very good. Well, we'll move on then to Andrew Servey. I'm sorry. I'm getting my. I'll just do it in the order that we're going down there. David Meisner.
Is this thing on? Check. Am I good? All right. Hi, I'm David Meisner. I work here at TMCC as a student worker in the Disability Resource Center, and I'm a Senator of Liberal Arts in our Student Government Association. I think the reason I'm here today, though, is because I'm alive. I think that's pretty much the only reason. So I got started really early on with drug abuse. I didn't even know it was drug abuse the first time I started doing drugs. I took a Vicodin. Something clicked in my head, and I thought, this is great. I like this. I think I'll go after more of this. It was like another year or two before I even figured out what that pill was. I don't know if I was a traditional drug addict or if I just didn't have any coping mechanisms with my everyday life, but either way, I quickly started choosing substances, any substance I could get a hold of, and most of the time those were prescription drugs, anything from Xanax to muscle relaxers, anything I could get to make me feel less me was great. That's what I wanted. I didn't want to feel like me. So I think that's why I got started. I never really delved too deep into that until I think 3 or 4 years into my addiction when I turned to heroin because OxyContin was too expensive. And I got to a point where I was paying about $1 a milligram for that stuff, and that was just ridiculous. A neighbor of mine said, here's some heroin, it'll probably do good for you, and it did a little too good for a while. I think about 5 or 6 years into my drug addiction was when it really got to its worst. I was about 105 pounds, standing at 6 feet tall. My skin was like tinted kind of green just from toxicity. My hair was always frizzy from lack of nutrients. I couldn't think straight. I had drug-induced schizophrenia. People avoided me. When I walked down the road, they would I mean, even at 110 pounds, 105 pounds, wherever I was, they would get to the other side of the road as to not look at me or have to encounter me. And I just felt like that's where I was going with life. I used to tell people that I was going to die on stage as a musician at 24. I'm 26 now, not dead, so that's good. So I don't want to spend too much time into the addiction. A lot of us know what that looks like, and if we don't know personally, we know somebody who's going through it. For me, though, the redeeming light was actually my rock bottom. I was with this girl at the time, and she was hooked on multiple drugs, and we were trying our best to raise her daughter. And one day I was in the bathroom shooting up, and she opened the door on me, and she saw me there. And even with the drugs, even with the numbness, even with that lack of humanity, as soon as she left, I just told her quickly, I'm sick, I need this shot. She was 4 years old, so she kind of just dismissed it, and she walked away. I collapsed and I fell on the ground, and I knew I was done. I couldn't do it anymore. I couldn't spread my sickness, and I was given an amazing childhood, and look at where I was, 110 pounds shooting up in a bathroom. And this little girl didn't have a choice. She was there looking at me right there. She didn't have a chance at all. And so I went to rehab after that. I went to a Christ-centered rehab clinic known as New Hope Recovery Ranch. They've recently closed down. They were out in Silver Springs. And it was there I was 20 or 21 years old. When I got there, again, 110 pounds, and within 6 months, I gained about 50, 60 pounds, and my humanity back. I could think straight. And I didn't need drugs to be me. I was able to look in the mirror, and I was able to be happy with myself. I was able to feel that hope again that I had just given up before I even knew I had a chance. So that Christ-based rehab was really, it opened up my eyes spiritually, and it showed me that there was coping mechanisms that I was lacking, and I had nothing, and so naturally I would turn to what I had, and those were drugs. Well, in rehab I learned how to turn to those who are close to me, how to ask for help, how to love. I learned how to love. That was pretty good. Yeah, if it wasn't for them, I wouldn't be here today. And to bounce off of what they were saying earlier is that this isn't just a fight for those who are addicted. This is a fight for everyone out there, because if somebody didn't fight for me, I wouldn't be here. My wife wouldn't be sitting here. I wouldn't have a kid on the way. I wouldn't be taking classes, and I wouldn't be happy. I might not even be here at all. So I'm going to share a poem real quick, and then if I have time, I'll go into a little bit more. To turn back time just a little and see what I looked like in the middle of my weakness. Weekends spent chasing, waiting, wasting everything on frequent visits to my own man-made gods. Isn't it funny how much time you can fit into such a little bag? A little mad, twisted, a little man wishing I had more so I could feel less. Like the dirt under my nails, memories never fail to evoke the sick sensation of smoke. Floating down my throat like a river of thirst, this my personal curse that I chose over family and friends alike. Not unlike many of you who still wander in the dark looking for that spark of life in the land of the lifeless, if only it was as easy as a light switch. Like suddenly I could forget how good it feels to feel good, and maybe just be okay with feeling okay. Now, if I have some time, I'll spend a little bit of time going over what I do to stay sober. For me, that's very different than many other people. For me, the 12 steps was great. I have a lot of friends who are alive today because of them, but it just was too many steps for me. I take a very spiritual approach, and I try and take one step in the right direction every day. I make sure that there's a lot that I have to lose in front of me. I have an amazing wife. I have friends who care about me. I make sure that I keep those in my focus point, because it's one needle away, and I could say goodbye to every single one of them, to everything I've built so thoroughly throughout the last 6 years. Again, for me, it's not that 12 steps. It's that one step every day, and And I think that people need to know that there are more options out there than just the abstinence program, the one-way-fits-all type thing. And again, I'm not trying to shame that program at all. I have many friends who are still here today because of it. But there are other ways. There's more of a spiritual approach you can take. You can be more mindful. I'm very mindful nowadays. I spend a lot of time meditating, practicing, just controlling my thoughts, because if I don't control my thoughts, then I know where they go, and my actions will soon follow. So I think that's pretty much all I have to say. Just if you know somebody that's struggling with this, please fight for them. They might be worth it.
Well, thank you, David. Do we have any questions for him? Any questions from the audience? Well, it sounds like a brave journey that you undertook when you gave that up. And we'll move on to, is it Danny Tillman?
It is.
Wonderful.
Thank you for sharing that story. I hear stories like that every day. My name is Danny Tillman. I am the Specialty Services Director for the Life Change Center here in, well, it's in Sparks. I always say here in Sparks. I'm also a counselor over there, and I get to hear stories like this every day, and it never ceases to amaze me that people that are addicted to substances, whether it be alcohol, prescription pills, marijuana, it doesn't matter what it is, cigarettes, caffeine, strongest individuals I know. And that's no joke, strongest people I know. So I wasn't always with the Life Change Center. I want to just share a piece of my background so that you understand why my journey took me to the Life Change Center. Well, I guess first let me tell you what the Life Change Center is. Life Change Center is a medically assisted treatment program. So we provide medically assisted treatment for individuals who are living with opiate addiction or dependence. Our primary vehicle for this treatment is methadone, although we do offer some of the alternatives. So it's a very specialized treatment program, and we currently have a client census of about 700 patients. We do have 2 clinics. We have one in Sparks, and we have one down in Carson City that we opened up about a year ago. So like I said, my journey, though, it didn't start at the Life Change Center. My journey actually began with another treatment program. I was employed by another treatment program that ironically is 12-step abstinence-based treatment program that provided residential treatment as well as individual and group counseling to individuals in the community living with all types of addictions, not just heroin. And it was my job to provide kind of ancillary services. I did a lot of workforce services, but I was surrounded by clinicians, and I was kind of knee-deep in this world of substance use treatment here in this community. When my then 21-year-old daughter called me from Seattle, Washington in the end of 2011 and said, "Mom, I'm shooting heroin and cocaine, and I'm really sick and I need help." So I immediately went to my boss, who, called probably JTNN and a couple of other places, and we pulled some strings, and we got her a place in a treatment program, and I set out to Seattle to go round up my daughter and bring her here and fix her. So I get to Seattle, it's the middle of the night, and my daughter's not where she said she was, big surprise, and I'm standing in the middle of the street, and I'm in tears, and I'm thinking to myself, what am I going to do? And I look up, and I see this figure walking down the road towards me, moving from side to side. I wasn't even sure if it was real. Okay, I was a little tired, it was a long drive, I drove straight through, I was worried, and I'm like, am I seeing things? And I hear, "Mom." And I look up, and there is my beautiful, beautiful daughter, who is about 84 pounds. Her skin was ghostly white, and she just collapsed in my arms. So I pick this kid up, I load her in the truck, and I watch her inject heroin multiple times on the trip down here just to get her here so that she was okay enough to get here. Hardest thing I ever had to see in my life. I put her in a treatment program, and if anybody's ever, been engaged in treatment or known people that have gone to treatment, it doesn't always work the first time, and that's okay. That's the good message here. It's okay if it doesn't work the first time, but don't give up. So it didn't work the first time for my daughter. She ran from that treatment program, and she continued to live on the streets for a while, using whatever she could get her hands on. I'd see her periodically here and there. She called me for Christmas. By now, we're just coming into the new year of 2012, and my daughter calls me and she says, "Mom, I'm ready to quit again. Can I come live with you?" I said, "Absolutely, but let's sit down, let's talk about this." And remember, I worked for this treatment program that was very strict in its abstinence-based philosophy. And so, yes, you can come live with me, but you can't use under my roof, and you have to get into a program. I don't care what program it is, NAGA, I don't care, just do something. "Mom, can I get on Suboxone?" "No." Because remember, that was what I was surrounded by. The conversation hadn't entered my treatment program yet for me to hear it. Okay, so no, you can't. No, you can't. But you've got to stop using, and you've got to do something, but you can't do that. On May 10th, 2012, at 5:30 in the morning, the coroner knocked on my door to tell me that my 22-year-old daughter had died alone in a bathroom as a result of a heroin overdose. That was the moment that my trajectory was changed. I decided at that moment that we could no longer have the conversation of one treatment program fits all. We could no longer have the conversation that a person has to get clean and sober on the first try, or they were in denial. We couldn't continue those conversations because we were in what we now know was the beginning of the biggest opioid epidemic that we have ever seen in this state. And we are losing people by the dozens. People are dying, our neighbors are dying, our children, our parents, our loved ones, they're dying, and we had to do something. I'm very proud to say that as a result of my daughter's death, that first treatment program that I worked for, well, first of all, I decided at that moment I was going to become a counselor. I couldn't sit by idly and watch others do the work that I then figured out that I was destined to be doing. And so I began my education to become a substance abuse counselor. And I had many, many long conversations with the executive director of that agency, and I'm very, very proud to report today that that agency is medication-assisted treatment friendly. They have houses that are dedicated to our youth who are addicted to opiate addiction, and they are fighting the fight for our children. But that wasn't enough for me. That wasn't enough. I needed to get in on the front lines of the MAT world. I needed to be able to truly understand the options that people with opiate addiction have, the treatment options that are available, the barriers to gaining access to treatment, and I needed to do something. So I made a move and I joined the team over at the Life Change Center, and I could not be more excited to tell you that we have a program that supports not just the medication component of treatment, but we have a phenomenal staff of 35, including this wonderful guy to my right, that continue to promote a sober lifestyle. So the individuals that will come into our doors, not everybody, by the way, that comes into our doors is seeking medication-assisted treatment. We do have a population of folks that come in for the other services, and those other services are group and individual counseling, one-on-one counseling. We have ancillary programs. I'm very proud to report that we were recently given the opportunity to fund a women's services program that's going to target women who are the most underserved of our addicted population for a multitude of reasons. But women with children under the age of 18 who are living with opiate addiction. I'm so excited that we get to roll this program out next month and start changing the cycle. Start having these conversations where people can be empowered to take control of their own lives, to change their destinies, and to change the destinies of our children. Because it's a really scary thought when I think about how many people are out there dying and to know that those people are the ones that are supposed to be caring for me when I get old. I need the generations that come after me to be healthy, to be happy, and to never, ever have to experience the loss of a child or a family member or a loved one because of opiate addiction. So I'm very, very happy to be here today, and I'm very, very happy to share with you that there are options. Everyone at this table has taken a huge stand and a huge fight against this epidemic problem, and we all have our flag to wave, and we all have a piece and we all have an investment here. You know, and like everyone before me has said, this isn't just my fight. This isn't just Brittany's fight. This is your fight. This is your fight. We've got to do this. We've got to do this. We've got to save our community and preserve it for our children and for our grandchildren. And I'm so grateful to all of the ladies that have spoken before me here today, some of whom I've had the pleasure of working with, although they don't recognize that because it was always by phone, and some of whom I do get to sit in community action meetings with. And I'm just very, very proud that Northern Nevada is the community that we are, and that we are determined to care for our community. Thanks.
Well, thank you very much. Do we have any questions for Danny? Any questions from anyone? Please.
Do you do primarily methadone, but do you also do buprenorphine and Suboxone?
Yes, we do. Our primary vehicle is methadone, but we actually utilize Subutex as well, which is very similar to Suboxone. It does not have the naloxone in it. So if you have more questions about the specifics of the medications, I encourage you to certainly talk to Carla, but you can absolutely call any of us, or you can call the Life Change Center. You can just Google the number. We are, like I said, we do focus primarily on methadone, but our primary focus is a complete biopsychosocial interview with the patient to determine which medication is the most appropriate, because there are indications that for certain patients, methadone is the more appropriate medication than Suboxone or Subutex, and vice versa. And we really don't know that until we get in and we do a complete biopsychosocial history and figure out exactly, you know, how old you are, how long you've been using, how you've been using, are you injecting or smoking, what you've been using, what your genetic family history is. I mean, there's just so many components to it that it's really not a black and white answer of Suboxone versus methadone. And so I'm really excited to see everybody here kind of getting this information, because there is multiple options out there, and just take the time to figure out which one's best. Talk to the professionals. They are happy to help you. And, you know, if we don't have the answer for you, that's okay. I've got an entire, I want to say Rolodex, but it's on the computer now. It's a Rolodex on the computer. I have a plethora of referrals that I can provide if we aren't the program for you. But, you know, walk through the door and ask the question. If you know anyone that is struggling with opiate addiction, you can pick up the phone. Just make the call.
Perhaps you could discuss very briefly what Suboxone is. It's a relatively recent phenomenon, I'd say within the last 2 years or so, perhaps 3, that this has become, it's a version of opiates, I know that.
It is a version of opiate. I actually, sitting here looking at this panel, I don't know if I'm the expert on this.
Well,
I can provide it. Would you like to do?
I can help a little, but
Okay.
I'm not a
please.
physician.
Okay. Well, I'll go ahead and give my spiel, and please jump in. So methadone, everybody's heard about methadone. Methadone has been around forever. It was primarily used, in the beginning, it was primarily used as a pain reliever. And in small doses, methadone is very, very effective for a pain reliever. It is an opiate analgesic, so it is a synthetic opiate. And it has a very, very long half-life. You heard us talking a little bit about half-life, short half-life, long half-life. Heroin has a very, very short half-life, which is why folks get that euphoria. Heroin, if you can imagine in your mind here kind of a really steep bell curve, That's kind of how heroin works in your system. So it takes you up really high, really fast, but it doesn't last very long, and it drops you really, really hard, really quickly. Methadone, on the other hand, has a very low bell curve to it, and the general half-life for methadone is 24 to 40 hours, so it's going to stay in your system for 24 to 40 hours to help suppress the cravings for heroin addiction. That is what makes this particular drug so effective, is that it doesn't give the huge high, and it stays in your system for a very, very long time. Now, you know, as we heard earlier, there are risks. You know, anytime you use an opiate analgesic, there are risks. Long-term opiate exposure of any sort has risk. And there is absolutely a risk of overdose on heroin, and sometimes it is that combination of heroin and benzodiazepine or heroin and alcohol. We actually monitor for that very, very closely with drug tests, urine analysis. We also monitor the PMP so that we can ensure that, you know, someone's not reporting a benzodiazepine prescription when they come in and get methadone. And by the way, methadone is a prescribed and monitored substance. So then we switch over to Suboxone, which really came out and hit the conversation somewhere around 2013-14. It really just kind of went, hey, here we are the cure. And for some, that is absolutely true. Suboxone is another opiate analgesic. It is its brand name, or it's it's buprenorphine is what it is. And Suboxone, you heard us talking about naloxone, the reversal agent. That is in Suboxone. So methadone is a full agonist, so it attaches to the opiate receptor and it just kind of hangs out there. Suboxone is a partial agonist because of the naloxone in it, the buprenorphine. So what it does is it attaches to the opioid receptor much like methadone does, but what also occurs is that if other opiates are ingested into the system and try to attach, the buprenorphine will kick the opiate off of the receptor. So there's some things that come into play when you start talking about which drug is most appropriate for which kind of person. And you know, there's some statistics that would tell us that people that are long-term IV drug users with a significant history of relapse are probably better suited to be treated with methadone. There is other data that tells us that people with a very short addiction history who have not reached the point of IV injection use are better suited for Suboxone. But one thing that's important about Suboxone is that there's a ceiling on it. You can reach a point with Suboxone where no matter how much you take, it's not going to work. And that's why it's not as effective with people that have long-term IV drug use, because more often than not, that tolerance level is above the ceiling of Suboxone. And that's why it's so important when we have these conversations that we include all of the different options, the Suboxone, the Subutex. Subutex is the same thing as Suboxone, but it doesn't have that Narcan piece in it. Or the naloxone piece. And it's important to have the conversation including methadone, because all three of these medications do very, very specific things, have very, very specific outcomes, and are really good options.
Thank you very much for that.
I just want to add one more piece to the post. We're using a lot of words that sound very similar, right? Naloxone, Suboxone, and the other word you might have heard, the other medicine you might have heard about is naltrexone. And we tend to get them like really conflated because they all sort of sound similar. So methadone and buprenorphine are drugs that are used in medication-assisted treatment. Buprenorphine can be Suboxone if it has naloxone added to it, right? The reason we add naloxone to the buprenorphine in Suboxone is as an abuse deterrent, so that people can't use it in other ways to try to get high on it. So some of these things act as agonists. They turn on a receptor. Where's the like biology people?
Where's our biology folks?
Right? You have opioid receptors in your brain, and some of these things act as agonists. They turn them on. Some of these things act as partial agonists. They partially turn them on. And some of these things work as antagonists and block the receptor. So when you're talking about medication-assisted treatment, you're talking about things like methadone, buprenorphine, which is the brand name is Subutex, or Suboxone, which is the buprenorphine plus naloxone treatment. If you're talking about treatment for alcohol addiction and some other things, you might be talking about naltrexone, different. Or if you're talking about reversing opioid overdoses, you're talking about naloxone. The brand name for naloxone is Narcan. They all sort of sound similar, and I don't know why we did this to ourselves.
Right? Yeah. It's very confusing, trust me.
What about Vivitrol?
Vivitrol.
Is naltrexone. Vivitrol is the brand name for naltrexone.
Right.
Vivitrol is amazing, but there's some challenges right now with Vivitrol. The first is that it's really expensive.
Right.
It's really expensive. Vivitrol is a once-a-month injection that can be given to folks with opiate addictions, and it's naltrexone. See, I get them all confused, but,
Extended release naltrexone.
pardon me?
It's the extended release.
Extended
version.
release naltrexone. So it is super effective, but it's super expensive. And there are, I believe the Washoe County Sheriff's Department just received funding to begin, am I correct here, a pilot program for injecting opiate addicts pre-release. Am I speaking out of school?
That's the plan, I'm just not sure what we know where
Okay.
I don't think they've gotten the money, but Northern Nevada Hopes does administer Vivitrol, so if anybody is interested in Vivitrol, and the data, I went to an Alkermes, that's the manufacturer of Vivitrol, presentation not too long ago. The data is really good. You don't have to stay on it forever, but the idea is to clear the mind enough so that the person is not thinking about their drug all the time, to help them, get coping skills, et cetera, to be off the drug. So I think in the Alkermes studies, they were on the drug maybe, I think it's 3 to 6 months, and our Medicaid does pay for it now. So it's, it's on formularies right now in our state.
One of the other important distinctions between methadone and buprenorphine, and one of the changes that happened, which is why we talk about it more, methadone is federally regulated and federally controlled, and you have to go to a federally controlled clinic. I'm looking for my cassette people here. Buprenorphine can be used in office-based outpatient treatment. So physicians who have a DEA license can prescribe buprenorphine out of their offices. And so that was designed to increase availability. And very recently, in the past couple of years, federal legislation changed to expand the caps. There was a cap on how many patients each doctor could have, and they raised that cap so that doctors can be prescribing more. And so that gives people more options to go to a methadone clinic or go to an outpatient office-based program.
Did you have a question? No, I thought I saw your hand up.
Earlier, you were talking about women and going into treatment. What about their kids? Maybe Stacy would know this better. Are kids automatically taken away from women that are addicts that need treatment? Because I wonder if that would be a deterrent for someone wanting to go there.
Well, I can tell you that from,
Situation with that if you have a child and you're looking for help.
I can tell, absolutely, you have probably a better answer on the legal side of it, but it is the number one reason why women aren't entering treatment programs. That's the data that we've collected, and that's the data that we've collected specifically from the women in our program as to the timing of their entry to treatment. I didn't come sooner because I was afraid I was going to lose my kids. We serve a lot of women that are pregnant. And opiate use during pregnancy, that we could do a whole nother panel on that, right? But the real fear here is that I'm going to lose my child. And we can tell you that we've had a lot of conversations with law enforcement in the community, and these ladies here have done such phenomenal work that the perception by our patients is changing, and they're beginning to enter treatment sooner. Now, from the legal perspective, I would have to hand that off.
I would like to, we have a limited time here, and I would like to hear from Andrew Survey, and perhaps some of the other notions will come up that are circulating here with this nice response we're getting.
Yeah, I'd just like to say with the panel that you guys have here, you guys are extremely lucky. And we're also extremely lucky to have you guys here listening, because what you're going to be able to do is spread this out there. And I think that's one of the hardest things about substance abuse. It's never talked about, and, oh, hey, did you hear about that great substance abuse story? It's never that, it's the hush-hush world. So I feel incredibly lucky to be here with this group. You have no idea. So please, if you guys have questions while I'm talking, just raise your hand, because any information you can get from these experts, get it now. Put it out there to the community. The reason I work with Danny at the Life Change Center, real quick about me, I was born here in 1971, right there at St. Mary's. This is where I love and where I'll always stay. The only time I've left Nevada on purpose was when I joined the Army, and I was stationed at Fort Stewart for 10 years, just under 10 years. And as a combat medic, you see a lot of different things when it comes to prescription drugs, alcohol, everything. So when I came back to Reno after getting out of the military, I wanted to do something for my community. Initially, I tried massage therapy. Went to massage therapy school because I wanted to work with vets with PTSD, so that you could, go like that and touch them without them trying to punch you. And that's just the straight up facts about it. That's what I wanted to do. Got in a car accident, lady rear-ended me, ruined my wrists. I can't do that anymore. So being a medic, I wanted to help my community, wanted to help where I was born, and heard about the Life Change Center. Now, I'm extremely new to the substance abuse community. I'm blown away by the amount of time and energy that people like Danny and these ladies here and this gentleman here put into their community that needs their help, whether they want it or not, whether they get rewards or not, whether they get thank you letters or not. These people go out there, and I've seen Danny do it multiple times. She's not getting paid for it, but she's sitting there stressing about, how can I make this class better? I got this group coming up, how can I make this class better? She could go in there and give a group, sit there and talk to people, have a group, okay, great, check the box. These people don't do that. I've seen the way these people act about this. They put their whole entire heart, mind, and soul into this. And why? Danny's got a really good reason. She's lost someone to addiction. I'm sure every single buddy in here knows somebody who's lost someone to addiction. If you haven't yourself. I know I have. It's too common for you not to be touched by this problem. So what this community is doing, to me, makes me proud to be someone who is from Nevada, lives in Nevada, loves Nevada. I will never leave, and I'm not licensed in any way. I'll just be straight up with you. Besides being a combat medic, which doesn't transfer into the civilian world, I work the front desk. I see these people every day. They come in, they talk to me for about this long. But what I do see from them is this. Since I've been there, you can see the change happen in people when they come out of a group or when something good happens to them. When they do get their kid back. When they do get to go up to their family and say, hey, I'm clean for the last couple days because of this. Or I didn't get this disease because of a needle I turned in and got a fresh one. Stuff like that. That is what this community needs. And like I said, I was born here. My mom was born here. We need this. Use these programs and these people because they want to help you guys. Help people you know. Use them.
I have a question. We've been talking about opioid, prescription-based opioid abuse. What about black tar heroin? I've heard in general conversations and reading in magazines that that's fairly common too, and there's a fair distribution of that throughout the country, and so that if people aren't taking OxyContin, they may be taking black tar heroin. And then, of course, there's the Chinese thing with fentanyl, which is very deadly. I don't know if you can address that in short, any of you?
I'm going to talk about the trafficking, and I'll talk about the epi.
Yeah, so depending on where you are in the country, different forms of heroin will be predominant. And so here in Nevada, we're close to Mexico. The majority of our heroin comes up from Mexico, and that's why it's referred to as Mexican black tar heroin. It's called black tar because it looks like black tar. It looks like little tiny chunks of tar. We occasionally encounter more of a powdered heroin that's brown here on the West Coast, but what you might have heard of as China white heroin, like was in Pulp Fiction, is more East Coast. We rarely, if ever, see that form of heroin here. We kind of have the opposite going on with fentanyl nowadays. We have encountered some fentanyl here, but if you hear about what's going on the East Coast, they're getting hammered and people are dying left and right of fentanyl overdose. It's much more common over on the East Coast. A part of that may be because their heroin tends to be powdered. Fentanyl tends to be powdered, so it's easier to mix. It's difficult to mix something in with black tar heroin. So there's just regional differences. Heroin is still heroin at the end of the day. What it does to your body will be the same. But black tar is primarily the form of heroin that we see here.
So what we understand from an epidemiological or a public health perspective is that there are multiple things going on, and it's a very complicated relationship between prescription opioids and heroin. We've seen increases in prescribing, so there's lots more prescription opioids, which leads in some cases to diversion, leads in some cases to addiction. And then when we see a restriction on that prescribing, and people can't get it or it gets too expensive because all of a sudden it's $80 a pill, right? And I'm addicted and I can't get into effective treatment, then I need something, and so some people switch from prescription opioids to heroin. But what we also know is that we've seen changes in trafficking of heroin, and the heroin market has changed such that, and my data are a little old, so you can correct me because I'm sure you have newer stuff, purity has increased, quantity has increased, availability has increased. So there are two things, and they're sort of operating simultaneously and a little bit differently, but we see these transitions, right? But we also we're seeing dramatic increases in heroin-related deaths. We might be seeing a little bit of tapering in terms of prescription opioid-related deaths, but we're seeing big increases in heroin-related deaths. And in places where they're seeing fentanyl is so potent, and it's killing people very, very fast.
So here in Reno, you are seeing the shift over to the black tar heroin deaths. Seemingly, the statistics indicate that.
Yeah, I mean, it's hard to say. That's why one of the focuses of this new research project is to look at, is it a linear progression that I use Vicodin and then OxyContin and then heroin and I never go back and forth? Or what we're starting to see as we get early finding is that using both in the same period of time is more common than we would have thought. So it may be that on certain days I get lucky and I'm able to get some OxyContin pills and I use those. And on another day I can't get any, or they're too expensive on the street, so I use heroin. Because, like I said, either one will prevent withdrawal for the other. So it's hard to say. And then nationally, they've been looking at that too. Some studies have suggested that it may not be, the increase in heroin use may not be because we're cracking down on prescription drug use, but it may just be the natural progression of addiction. That, eventually this drug isn't doing it for me anymore, and I need something else.
So then they would go to black tar heroin.
Yeah, I mean, heroin is very effective, so. Drugs work, that's why we do it.
Thank you, sir.
I have a question, and I got to preface my question because it's not rooted in callousness or ignorance, because my wife was a cop for 10 years, my father's a substance abuse counselor, and my father, or some of my siblings are addicts. But my question is this: aren't programs and legislation and all these things just attempting to fix symptoms and not cures? Because we have programs for people who are already addicted and recovery programs for people who are already addicted, but the addiction is stemming from something else. Now that's a big question, and whatever the something else is, but like how do you deal with, instead of just the symptoms, the cause?
Can I respond? See, that's why I represent prevention here as a coalition, and Stacy too. And realistically, when you look at prevention dollars, like in our state, 80% of the dollars for the block grant goes to treatment. I get it, but 20% goes to the prevention piece. So if we put more effort on the prevention end to begin with, and we do as a coalition, and other coalitions do the same thing, we fund evidence-based programs in the schools with families, around the community. They're so limited, though. We have such few dollars. And I agree, the federal government needs to look at that, too. When they're looking at all of these programs, if you start in the beginning and you make sure that kids have coping skills and they know how to make good, not just good choices, but behaviorally, that's where I come in on the prevention piece. So I mean, there might be other answers here, but I really feel passionately about prevention to begin with.
That was going to be one of my questions,
Okay.
is what are you doing with the schools?
Right. So we do a lot of things. Yeah, we have teenagers. We have a youth program where we have 11 youth, and they pair up and they go out and they talk to younger youth about drugs. Right now they're focusing on marijuana, prescription drugs, and alcohol. And they have lessons that are evidence-based lessons, but we also have individual different programs in the schools. We have a Parenting Wisely where we talk with parents of young kids to help them before the kids, progress into anything. And we have specific programs. We work with the Children's Cabinet, Boys and Girls Club, Big Brothers Big Sisters, Accept, Quest. So we work with a lot of agencies.
And I would say your other things that you've talked about today are prevention efforts. Reducing drug diversion, controlling pills in a home, drug take-back days, checking the prescription drug monitoring program, and working with prescribers around opioid stewardship and considering alternative pain medication regimens. That's prevention. A lot of this stuff that people have talked about today is prevention.
And then you have the clinical aspect of it that kind of comes in at the tail end of this. And you're right, the drug use itself is just a symptom of a much deeper, much lower-seated issue. And so we spend a lot of time using cognitive behavioral therapies, existential therapies, different person-centered therapies. We use an integrated therapy approach to get to what the root of the problem is, because you've got to change the thinking. You've got to change the thinking. If you change the way you think about the drug, if you change the way you think about what the drug does for you, the behavior is going to follow. But we've got to get you stable. We've got to get prevention out there telling our kids that they don't have to use. And we've got to have the people that are doing the research to figure out what is the best approach. We've got to have every single person that's sitting up at this table today. We've got to have law enforcement at the table. We've got to have social services at the table. And we've got to have you guys at the table.
It seems like what he was saying also is it's an ongoing battle. I mean, people like to get high, and they will experiment with it, and it will escalate, and they will find it. Like you said, we're close to a border, and so it's an ongoing battle, and there perhaps are not enough resources.
But there's also favorable laws and norms. So if youth, like in our community, when we did our focus groups, unfortunately, there were a lot of risk factors for our youth, not a lot of protective factors. We live in a community that's 24 hours, everything is going 24 hours. There's access to drugs and alcohol all the time and never stops being sold. We have issues in our state that are different than other states. And that's something that we have to look at as a community, and we've just legalized another drug, marijuana. So our kids already right now, 50% of them, a little more than 50% feel like they perceive harm for using an illegal drug, marijuana. Okay, in the last data, now it's legalized. We have 1 in 4 teenagers who say they're using it right now. So until we have some sort of perception of risk, or that there is going to be maybe something that happens to you if you use alcohol, marijuana, whatever it is, when we talk about addictive drugs, kids have to perceive that there is something, first of all, else for them. So like other options, and maybe if you use this option, alcohol, marijuana, whatever it is, it doesn't mean that that's the only drug you're ever going to use in your life. It could lead on to something else. But they have to understand they have other options. In our community, I'm just telling you, they don't always perceive that there are other options. If that made sense.
Sharon. Could you speak up quite a bit? Could you speak up?
I'm not sure that addiction in the 21st century is necessarily an anomaly. This has been going on since the 19th century, particularly for women. My feeling is that the media and Hollywood, that we starting in the 50s and 60s, have glamorized the use of recreational use of drugs, and that we need to really start thinking about the message that's being put out there for young people.
Sharon has done substantial research in opiate use on the Comstock among prostitutes. So, as she's saying, what?
It wasn't just prostitutes as well.
Oh, just general usage? Thank you.
At fringe levels, but I just am thinking about the 19th century sensibilities. And on one hand, they're really, in terms of gender, they're not that different than they are now. The only thing that's different is that the media's portrayal of drug addiction is very different. And so I was just thinking somehow we could change that tone, change that dialogue to some extent. That would make a difference.
Thank you, Sharon. Are there other questions in the, yes?
I'd like to thank you, the panelists, for coming today. The illumination is just unbelievable. I think you've opened so many eyes. The inception of the concept for this afternoon came about a year ago. I teach a film class, and I would show Requiem for a Dream. I saw that about 13% of the students had an addiction problem. Then Dr. Rand, who was my mom's doctor, well, we know what happened with him. The third factor was I was doing library orientations, and the concept came up about heroin epidemic, and I had in one class and then another class a week later, two substance abuse counselors. They told me that to buy heroin on the street was $8 a high, an all-day high. And I sat there and I said, I go to a pub, I get 2 pints of beer, it's $10 maybe. Heroin is cheaper than 2 pints of beer. And just totally floored me. I had no concept. I thought it was $80 a high, $8, and I said, oh my gosh, I understand why there's a curve like this. Is that true about, I know it starts off at about $8, but it very quickly escalates, I imagine, to about $60 to $100 to $200 a day, depending on the individual.
Mm-hmm.
And that gateway of cost is probably something that is incredibly disturbing to all you panelists in the sense that it's just such an inviting avenue for a high, coupled with it's such an economic value for a high, and the belief is that I can try it once and that's it. Is that the predominant philosophy towards people who do approach heroin?
I would say I don't know that there is a predominant philosophy, to be honest. I mean, people initiate substance use for any number of reasons. They're as unique as the person. Heroin is very cheap. Those prices are about right. Drugs do tend to have a quantity discount associated with them, just like Costco. So if you were to buy a pound of heroin, you'll pay less per 0.2 of a gram, which is what's considered one dose. So it's a combination of factors, I guess, would be my answer to that question, and then I'll...
Yeah.
Is also the statistic probably close to 1 in 10?
Of
1
what?
in 10 what?
Addiction amongst a certain age group?
It depends on the substance. For opioids, I don't know off the top of my head.
Yeah, I think you'd have to.
Probably hard to get that one.
have to look at a lot of different areas. I'm sorry,
dial
I
that
just
in a
have to
little
ask
more.
that question.
Oh,
one
please,
time
please.
About the women, because,
Yeah.
I work with the counseling center. I want to know, what do I tell a woman that has a child or is pregnant to encourage her to seek help if she's worried about it?
If she's pregnant, I would tell her pregnant women are given priority in entering treatment. So, because it's such a need and there's such a great risk. As far as kids, I don't know that I could say whether the children are automatically taken away. I know the overarching goal of social services is reunification of the family whenever possible. I have a friend who just entered treatment and has a small child, and he still is able to see his kid. So I don't know that I could say if there's a blanket.
More willing, and like if you sought treatment,
Right, that would help your case, I would think, yeah.
like if the police came to
Right.
your house because of the neglect issue.
Yeah, I mean, that's what I was thinking. There's also a risk of having your children removed for being in a drug-using environment, because that's a great risk for the kids. So So I don't know. For pregnancy, I would say, yeah, for sure, let them know that they have priority in receiving treatment. And then I don't know that I could say what's the common stance from social services standpoint. So that's kind of their call rather than law enforcement doesn't make those calls.
And step 2 does take women with children. You know that probably, right? Yeah.
And then, so I would assume that if they were to become clean during that time of pregnancy and their children were born clean, then there would be no risk of having a child removed at that point, right?
No.
Well, there's, if we're talking specifically about opiate addiction, there's some risks with a mother that's using opiates while pregnant. The last thing that we want to do is put a mother who is using opiates while pregnancy into withdrawal, because that does increase the risk for miscarriage. So this is where some of that understanding between Suboxone and methadone come in. Methadone is an opiate agonist that you don't have to go into withdrawal to start the treatment, which is why we typically, we are one of the agencies that does offer priority service to women who are pregnant. But we offer primarily methadone for this because we can't send a woman into withdrawal. What we have done is we've fostered very good relationships with some of the OBs in town, as well as we continually try to educate the hospitals. And what we find is that, kids that are born addicted to methadone, may or may not. There's no checkbox that you can answer that question of whether or not CPS is going to be involved. What I can tell you is that the sooner they get into treatment and they stop testing positive for illicit substances, the better their chances are at reunification faster, if not complete unification from the beginning. But it's a coordination effort. You've got to coordinate with your doctors, you've got to coordinate with the treatment providers, and you've got to encourage these women to talk to both. Be open with the OB, because if the baby tests positive for methadone at birth, now we've got another issue.
Okay, well, our time is up. Thank you so much for coming in. If there's any last questions here before they leave, do you have any? No? Then, it's 4 after 4. Thank you very much.